Hey boot campers, welcome back to another video. This is David, your guide to gastroenterology. We're going to be continuing our embryology chapter today with a very high yield chapter, atresias and pyloric stenosis. So our atresias, we're going to first begin by talking about our intestinal atresias. Now, our intestinal atresias sound like they would be really closely related, but actually duodenal and jejunal and ileal atresia are fairly separate entities. So the first thing that you need to know is that all of these different intestinal atresias, when we're talking about infants, are going to result in a few things. In utero, polyhydramnios is going to be a big factor because when our gastrointestinal lumen fails to form, when the baby has nowhere to put that amniotic fluid, we're going to have polyhydramnios coming from that. Once the baby is born, however, there's going to be bilious vomiting. Now, it's important to understand that this is bilious vomiting because when we think about our pancreas in relation to our duodenum, our pancreas is going to pick up bile, and that bile is going to come down from our gallbladder, come down from our liver, and it's going to be excreted out with our pancreatic enzymes via the sphincter of Oddi at a place known as the ampulla of Vater. Now, this ampulla of Vater is a very important spot. This is where we have the change between the foregut and the midgut. So this is going to be our foregut region here, and this onwards is our midgut region. So this ampulla of Vater is kind of the mark point for the change between the foregut and the midgut, and also is where our bile is going to be excreted out. So if we have a closure in our duodenum, which classically comes from a failure to recanalize, specifically during the week 8 recanalization, when we have that duodenum being blocked off, the ampulla of Vater is still able to secrete out that bile. And so now we have all this bile hanging out down here with nowhere to go. And so when there is vomiting, it's going to be bilious vomiting. This is also going to result in abdominal distension. One thing examiners love to do is give you this very classic double bubble x-ray. The double bubble x-ray looks like this because everything entering into the stomach is going to dilate the stomach like so, and the duodenum like so, leaving you with a double bubble picture here. And this is part of the reason you have this abdominal distension, because there's nowhere for this stuff to go. So it's trapped inside of the stomach, trapped inside of the duodenum, resulting in the bilious vomiting, resulting in the abdominal distension. One thing examiners love to harp on is that duodenal atresia is associated with Down syndrome. Meanwhile, jejunal and ileal atresia, which are associated with the triple bubble sign, which you can see right here as our stomach, our duodenum, and then some portion of our jejunum and ileum, this is the triple bubble sign. And this jejunal and ileal atresia does not happen due to a failure in recanalization, but more often happens due to disruption of our mesenteric vessels. So remember, our midgut twists 270 degrees counterclockwise around our superior mesenteric artery. If this results, or if anything else results, in a disruption to the superior mesenteric artery, that is the reason for the failure in formation of our jejunum and our ileum and the rest of our small intestine. When those mesenteric vessels are disrupted, that is going to result in the tissues not forming because they don't have the blood supply to form. This is going to result in ischemic necrosis and then resorption of the bowel, essentially failure for that bowel to form in the first place. When that bowel doesn't form, when that bowel is resorbed, it's going to result in what's called an apple peel bowel, which is where the rest of that small intestine that fails to form, instead of becoming the small intestine with a lovely lumen which you're able to pass food through, instead it's going to shrivel up and twist around like an apple peel. While those small intestine atresias are fairly easy to pick out early on for newborns, biliary atresia is typically something that isn't noticed until a bit down the way. Biliary atresia most commonly happens because of an extrahepatic biliary tree failing to form. Intrahepatically, meaning inside of our liver, we have our hilum, which is the first area in which the biliary tree really begins to form, and then the intrahepatic biliary tree canalization happens from hilum to periphery. However, there's then the extrahepatic biliary tree. When this biliary tree fails to form, that's going to result in biliary obstruction within the first few months, and that bile is going to be backed up into the liver. When that bile is backed up into the liver, it has nowhere else to go. It's going to leak out into the blood. this is going to cause jaundice, and if it's not caught quickly, this can result in cirrhosis and liver failure, because that bile backing up into the liver is essentially going to poison the liver, and that can cause horrible downstream effects. If you're interested in learning more about biliary atresia and other biliary pathology, I highly recommend checking out our biliary chapter in our gastroenterology section. The final thing I really want to focus on here is pyloric stenosis, because pyloric stenosis is one of the NBME examiner's favorite questions to ask about, because it's such a unique clinical picture. So, the clinical picture that they will most likely give you is a firstborn male. So a mother having her first child, it's typically a male, and that mother may have a history of macrolides, specifically erythromycin use, that is going to increase your risk for pyloric stenosis. Now, what happens during pyloric stenosis? Well, first off, where is our pylorus? Our pylorus is right here, this connection between our stomach and our duodenum. It allows for the process of partially digested food, chyme, entering into our duodenum. And so the name pyloric stenosis makes perfect sense. The pylorus is becoming stenosed, it's becoming thickened, it's becoming hard. It no longer allows the passage of contents out through the stomach, and so everything's going to build up within the stomach. Because we haven't reached the ampulla of Vater, which we talked about previously, we do not have bile inside of our vomiting that we have from pyloric stenosis. Because of that, we have non-bilious projectile vomiting. Remember, the stomach is a thick, muscular, squeezing organ. So when you have a buildup of content within the stomach and nowhere for it to go, you can get very significant projectile vomiting. And what this repeated vomiting results in is a hypokalemic, hypochloremic metabolic alkalosis. If that doesn't immediately ring out to you as vomiting, then you need to lock that into your head for step 1 as vomiting. Hypokalemic, hypochloremic metabolic alkalosis. Metabolic here coming from the fact that this is a metabolic, not a respiratory process. Alkalosis coming from all of the acid loss, because the stomach produces a lot of acid. When we're vomiting, we're losing that acid. Therefore, we get alkalosis, more bicarbonate within our blood as compared to our acid. Hypochloremia, because all of the acid inside of our stomach is going to be hydrochloric acid. We're losing a bunch of chloride during the vomiting. And then hypokalemia, not really from potassium loss during vomiting, but more so from hypovolemia, then causing hypokalemia. Either way, keep in mind that this is the picture for vomiting in general, and you will see hypokalemic, hypochloremic metabolic alkalosis for infants with pyloric stenosis. Now, importantly, this doesn't occur immediately after birth. It takes a while for the pylorus to become stenosed, typically around 2 to 6 weeks. When it is stenosed, it's going to form an olive-like mass that is very palpable on the abdomen itself, and you can also feel a peristaltic wave on exam. Peristalsis being the progression of intestinal squeezing. The intestines are trying to pass along food. There's no food entering into the intestines. Instead, you just have this peristaltic wave on exam. Finally, if this pyloric stenosis is so severe that it needs to be surgically treated, this is done via a pyloromyotomy, which is a cutting of the muscles of the pylorus, thus preventing it from squeezing shut. To very briefly recap, we have our 2 different broad types of intestinal atresia, including duodenal atresia, classically more associated with Down syndrome and a failure to recanalize as opposed to a problem with our mesenteric vessels. This duodenal atresia double bubble is a very classic x-ray that you should familiarize yourself with. That could absolutely come up on your exam. Jejunal and ileal atresia, less associated with Down syndrome, more associated with mesenteric vessel disruption, and then an apple peel bowel. Next up, our biliary atresia, which we talk about a lot more in subsequent chapters, is going to result in biliary obstruction causing jaundice and then ultimately cirrhosis. And then finally, the question that examiners love, pyloric stenosis. Classically, it happens in firstborn males, mothers using erythromycin. It's going to result in non-bilious vomiting as opposed to our duodenal atresia and our jejunal and ileal atresia, which will have bilious vomiting. This is going to cause hypokalemia, hypochloremia, and a metabolic alkalosis. This happens a month to 2 months after birth, and it's going to cause an olive-like mass that can be treated with a pyloromyotomy. Thanks for watching. I hope you enjoyed this video, and I'll see you in the next one.